Moving straight on to the next presentation. So next up we have Dr. Julie McEniery and Dr. Diane Cruice from the Queensland Paediatric Quality Council, and they are presenting on the development of the Safer Infant Sleep Clinical Guidelines. Over to you, Di and Julie.
Thanks very much, Jamie, for the invitation. I'm very pleased to present with my colleague Diane Cruice today on behalf of the Quality Council on our pathway to developing some infant safer sleep guidelines, which was based on concepts very similar to the ones that Sharon has presented about making it easier for infants to sleep. And that came from reviews that we had done of sudden unexpected infant deaths. So I would like to just start by paying respects to the traditional custodians on the land of which we are meeting today, the Yagara and Turrbal people, paying our respects to Aboriginal and Torres Strait Islander elders past, present and emerging. So this wasn't just an academic interest to us. We have a higher infant mortality in Australia than the rest of, in Queensland than the rest of Australia. Looking at deaths per 100 live births and rate ratios, taking all the jurisdictions in Australia except Queensland as the rest of Australia group. So these are two discrete populations, and we used rolling 3-year averages. And you can see the difference in the infant mortality rates between Queensland and the rest of Australia. And there's an average of around about a 20% higher IMR in Queensland. We weren't sure how big a contribution SUDI was making to infant mortality and whether opportunities for prevention would make a difference. And one of the barriers to understanding the extent of preventable cause of death is the cause of death coding, which is so imprecise. Just as example, this is taken from the Australian Institute of Health and Welfare website, and it shows two issues. First of all, well, it doesn't show the relative proportions of death. It just shows them ranked in orders 1 to 5. But you can see on that top line where I've pulled out just the infants and new ones. You can see, as if they were discrete conditions, other ill-defined causes, sudden infant death syndrome and accidental threats to breathing. And yet we've just heard from Sharon, and certainly from our own work, we know that these really are part of a spectrum, and it's very difficult to differentiate. Still, using the ABS data, the ill-defined category R95 to R99 on the ICD-10 codes, we've had a higher sudden unexpected death in infancy from ill-defined cause in Queensland for many years. And even though that has narrowed a little, it is still a significantly different result with a rate ratio of 0.42. And then from a recent study of all Queensland infants born alive after 22 weeks over a 6-year spread, 1,400 deaths. And just looking at the cause of death, we have our answer to the question, how many are sudden unexpected deaths? In the neonatal age range, they're very much perinatal and congenital, but certainly in the post-neonatal deaths, the acquired cause is the most dominant cause. And of those, there's this subset of ill-defined cause deaths, which is comprise the majority of the deaths. So we have our answer to whether or not preventing some of these deaths would make an impact. So our process in the Quality Council is that we have an infant mortality subcommittee, and we receive linked infant data from statistical services, and also, and from that we identify deaths referred to the coroner. And then we get records for the mother and for the infant requested from hospital and health services, and the coronial records. And 2 members individually from this expert panel subcommittee, they review the documents and complete an online data form, and then we present the cases at a monthly meeting and develop consensus. And this is our committee, just to give you an idea of the hard work from all these clinicians and other experts who donate their time pro bono. So just to present some data from the 2013 to 2015 cohort. So we received the final coronial reports for these in 2020, if you're wondering about the delay. Some of these processes take a long time. But we identified 239 post-neonatal infant deaths and 576 neonatal deaths. From the neonatal deaths, we selected the neonatal SUDI by looking at the coronial records and looking at a cohort of records. But we looked at all the neonatal deaths, all the post-neonatal deaths, because we weren't certain whether just a high-level view would tell us whether or not they were truly SUDI. And from that review, we ended up with 132 post-neonatal non-SUDI deaths. And this is our study population here in the blue of neonatal and post-neonatal SUDI, 125. And then we were looking at sleep-related deaths from these 125, the majority occurred apparently during sleep, 116, although 4 of those were due to fatal inflicted injury. And then there were another 9 where we were uncertain if they were asleep. They might have been breastfeeding or found moribund. But it did leave 112, which was the majority of SUDI, which occurred in sleep. And so therefore the sleep circumstances were possibly relevant. And we divided these into infants who were shared sleeping with an adult or other person and the infants who slept alone. I'll go through these data, but I will show a graph that explains them if you're having trouble seeing. So we identified 8 different SUDI risk factors. We didn't consider shared sleep in and of itself as a risk factor. And we compared shared sleep with infants who slept alone just to get a feel for which factors were predominant. And we were very much interested in position place to sleep, but we created a variable called adjusted position place to sleep. Now, I'll just take you through the journey to get there. We worked further on the initial work that was done by our colleagues, Roger Bayard and Rebecca Shipstone and Janine Young, who used lividity over the anterior surface of the body or over the face to adjust the position to must have been prone when the circulation stopped. That was the position found. But we went a step further and said, well, if the baby was found prone and the baby was too young developmentally to roll, the baby must have been placed prone. And so when we did those 2 things, looked at anterior or facial lividity and then looked at the developmental age of the infant, we found that up to, or just a little over 70% of infants who slept alone could be considered to have been placed prone, whereas only 30% were stated to be placed prone. We didn't adjust for shared sleep because we reasoned that an adult turning in the bed could easily passively cause an infant to roll. And so, of course, the supine levels took the journey in the other direction. So another unsafe sleep position for the SUDI who slept alone was being positioned head up or propped or on an incline, with nearly a quarter of them in that position. And Diane mentioned further while we're so concerned about that as a sleeping position. Another unsafe position in the shared sleeping was the infant sleeping in the adult's arms and then the adult falling asleep. Thick soft bedding was a huge risk, over 2/3 in both categories, and sharing sleeping with adults affected by prescribed or illicit drugs or alcohol was another risk factor. And then smoking in pregnancy was well above the Queensland average of only 15%. And there were infants who were found after sleeping on an unsafe sleep surface, a surface not intended for sleep, but they were in the minority. So what that means is that our sleeping factors, and we've included smoking in this because it affects the way the infant responds during sleep, particularly soft bedding, being placed prone, an inclined position, and unsafe positions with a co-sleeper were the ones that we focused on. And then when we looked at the whole group, we discovered that, unfortunately, in the shared sleep group, over 40% didn't have all the details that we needed listed in their police investigation. The investigation was much more precise for the SUDI who slept alone. Regardless of whether factors weren't mentioned, still almost 100% in both group had unsafe sleep factors. You remember Sharon mentioned 75%, but we were in the 90% range for both. And so you can see the discrepancy between shared sleep and slept alone where there was documentation of sleep factors, but certainly the unsafe sleep factors were incredibly high. So final closing categories, and again, I'll show you a graph that explains this, but we started off with most of the SUDI having been officially categorised as SIDS, and then relatively equal numbers of natural cause and undetermined cause, and very few aspiration. And our final categories completely flipped those, and so we ended up with natural cause and SIDS dropping to very low levels, and the undetermined category and the accidental suffocation increasing a great deal to 22%, which is a ballpark similar to Sharon, who mentioned theirs was 18%. So just wanted to finally focus on this suffocation, or on the reclassification. We didn't, as I say, we didn't use shared sleeping as a standalone risk factor, but we were interested if we were biased and we were somehow more willing to recode deaths from shared sleep versus deaths when the infant slept alone. And the blue here is the shared sleep infants, and the purple is the infants who slept alone. And it's interesting that there wasn't really any difference between the two groups, but in both groups, the number of natural cause deaths reduced and SIDS, and in both groups, the number of undetermined cause increased and accidental suffocation increased. And then finally, just on the accidental suffocation, we found in 18 of the 112, there was a real possibility of suffocation. The infant was described as being face down on an object or up against an object, either a person or a piece of bedding. But it wasn't sufficiently described as being pressed into that object, and we couldn't sort of exclude that the baby was somehow resting on its little nose and perhaps still had a preserved airway. And then we found another 41 of 112 infants where we thought there was probable suffocation. In 26 cases, the infant face was pressed into a soft surface. In 3 deaths, the infant was said to have been overlaid by another person, but there was no recording about where the face was in that overlay. And then in 12 deaths, the infant face was covered by thick bedding. We don't just mean a sheet, we mean, thick adult doonas. And so really well over half these infants, we thought there was either a possible or probable suffocation, but we finally coded these as suffocation in only 19 of these probable causes. That's only 17% of the SUDI during sleep. And those were the cases where we had enough of a scene description to be able to be, a reasonable level of certainty, and where there was a complete post-mortem, so other causes were ruled out. So we use this information to inform prevention, and I'll hand over to my colleague Diane now to take us on that journey.
Thanks very much, Julie. If you want to just progress to the next slide. So the information that we used, we wanted to inform the development of our new safer infant sleep guidelines. However, just waiting for the slide to come up. As Sharon pointed out in her talk previously, it's not just a matter about having guidelines, it's how we know what we know about parents are doing generally in the community, but also how do we get those messages across? And we were very lucky to have some great information, not only from the SUDI deaths in Queensland, but also Queensland Infant Care Practices Study, which I'll talk about in a moment, and some great work on how do we get those messages across. I'm not going to go into a lot of detail about the exact specifics of what's in the guidelines in terms of content, but if you need to find them, you can easily Google Queensland Clinical Guidelines, and we're there under neonatal guidelines. You'll find the Safer Infant Sleep Guideline. Thanks, Julie. So what did we know about what Queensland parents were doing in terms of sleep situation? Well, thanks to Dr. Ronnie Cole and Professor Janine Young from the University of the Sunshine Coast, they conducted the Queensland Infant Care Practices Study. I'm not going to go through all of the information in detail, and there is certainly a lot more information in these studies, but just wanted to point out that obviously not the safe sleep guidelines or the things that are suggested as the key messages are often not being followed by parents in their day-to-day caring for their infants for various reasons. Just want to point out these last 2 points, that 55% of mothers place their babies in an inclined position if they have concerns about reflux, and that over 20% had used a pillow with their infant at some point. Thanks, Julie. The other things that we wanted to get a look at were communicating with caregivers, and thanks to Anna Peace and her colleagues in the UK who did a large review in this area and found that interventions can't be just a one-size-fits-all. They have to take into perspective the parent's perspective, their circumstances and their experiences. And also Middlemiss and her colleagues in the US found that behaviour was more likely to change when there was an understanding of what the risk was or why there was a risk, rather than just being told to put your baby on your back. And they also recommended a GIST format. So GIST is where you summarise things very succinctly into one neat message for parents to easily be able to understand. And then Stephanie Cowan and the Change for Children team in New Zealand put together a fabulous education package as part of the PepiPod program, where they relied heavily on this type of communicating with parents, and they coined the phrase easy to breathe, safe to sleep, which resonated hugely with our working group, working through the guides. And Stephanie was very gracious in suggesting that we continue to use that phrase, not only within the guides, but to really use it wherever we could to, I guess, bring to life their next GIST message was to share your knowledge and protect all babies. Thanks, Julie. So the actual guideline development was quite structured. We did it in collaboration with the University of Sunshine Coast, Professor Janine Young in particular, and Queensland Clinical Guidelines, who have this role of guideline development happening all of the time. Our clinical lead group was Julie, Janine and myself. We had a working party of 105 people in the end, so a large range of professionals across the state. We also had GP representatives, we had consumers, and we had members of peak bodies such as Red Nose, Australian Breastfeeding Association, Australian College of Midwives, just to name a few. Our working party actually went through 2 complete reviews of the guide because it changed so much between one and the other. We then went to statewide consultation for more feedback and incorporation. The guide was endorsed by the key councils and networks for maternity and paediatrics in Queensland and finally released in July last year. Thanks, Julie. Just to give you an overview of the guides, the key safe messages are still there and are still important, but we're really wanting to capsulate that within a risk management approach and how we communicate to caregivers. So we have a whole section on communicating with caregivers and what's recommended. Sorry, Julie, just thank you. We also focus a lot on mechanisms of airway protection, which was something we hadn't seen so specifically in a lot of guides, but it really was to talk about this, as Sharon mentioned, and also Julie, how do we talk to parents about keeping babies' airways safe to reduce this risk, this real risk of suffocation in the sleep space? And then finally, within the guides, there are lots of specific strategies for safer infant sleep for clinicians to use with families. But really only once we've got this key message across, we've communicated it well, and we feel that everyone's understanding how to protect infant airways. Thanks, Julie. So obviously within this session, we're focusing on the mechanisms of airway protection, which was just summarised there, but I'll go on to it in more detail. For example, on the next slide, we have within the guides, what we've tried to do is encapsulate the risk factors in succinct forms in tables so that clinicians aren't wading through lots of information to get to what they need, but also in a way that can help them understand and relay that to parents. So this was just one table about the mechanisms of SUDI in the infant sleep space, and I couldn't resist putting this Facebook ad with it, where the quote actually says, "Did you know that babies have an off switch?" which is quite ironic in this situation. So the number of risk factors in that advertising picture there, I'm going to leave for Ruth in our next presentation to go through, because she has some doozies, certainly. Thanks, Julie. We also, when we looked at things such as supine sleep position or sleeping your baby on your back, this is in every safe sleep messaging, but we really wanted clinicians and therefore parents and caregivers to understand that it's not just placing your baby supine helps make babies safe, but that placing them non-supine actually increases the risk of SUDI, and how that increases the risk of SUDI rather than just believing that that is so. So we covered that as well. Thanks, Julie. Next one. We were very fortunate to be able to use the data that we had in Queensland, both the SUDI reviews that we had done and also the work of the Infant Care Practices Study, to know that incline position was a real issue. We had around 25% of our deaths were found in a propped or inclined position, or not found, but had been placed to sleep in an inclined or propped position. And our reviewers really drilled down to how they felt this contributed. And it was sometimes because the infant had slouched down into more of a C-shaped position, compromising breathing, or had fallen forward or rolled forward onto a pillow, even though they'd shown no ability to roll previously. So we have a little video here that shows a little baby propped on a pillow quite nicely, thinking that they're all safe and ready to go to sleep. And with a bit of movement, their heavy heads tend to cause them to roll forward. Now, if that happens in the middle of the night and no one is there to rescue that baby, their face is generally pressed down into the bedding. Thanks, Julie. We also have quite a section on shared sleeping and safer shared sleeping, because we know that a lot of families, I think around 80 to 90%, will share a sleep surface with their baby at some point, whether they intend to or not. And as Julie mentioned, it's not so much the act of the shared sleeping, it's the environment in which the shared sleeping occurs. And is it the safest one possible for the baby? We put this into a model which included looking at different levels of care that parents need, but we adapted a 5A model in terms of to work with for our midwives and our child health nurses in terms of identifying what different sorts of families would need at each level. So obviously our universal need is asking all parents about shared sleeping and whether they intend to, how it looks, what can they do. And then secondly, in the next circle, we have additional needs. So those families that need a bit more support, a bit more of a plan, a direct plan, or what to do when things don't go quite right. And then finally, our families with significant needs who may need significant support to actually arrange a safe sleep space for their infant, including programs for priority populations, which may not even have a safe sleep space for their infant. So, for example, we just have a picture here of the PepiPod program being used. So this just gives you an example of a type of program that can be used when we're looking at families that are really high risk. And the majority of the reviews that we do would fit in that significant need or additional need. So a lot of our families where SUDI is occurring are the families that need that level of support. Thanks, Julie. And one last thing I wanted to mention was that the guide actually incorporates a section on infant development and SUDI. We found a little group of infants, well, not such a little group, but around 6 to 9 months of age who were becoming entangled in their bedding and found totally entangled in doonas and big blankets and things. So we wanted to include a section for clinicians to be aware that SUDI just doesn't sort of finish at 4 to 5 years of age when babies can start to move around and push up and crawl. In fact, the risks become more intense in other aspects of their sleep environment. So we really wanted to include a section on that. Thank you. And then lastly, just to say that we've used this information to look at other things as well, not just the safe sleep guidelines. We've done a review of the PepiPod program in terms of its impact on population infant deaths in Queensland, and found it did make a real impact, a huge impact in those communities where it was used. So we're now working towards trying to get that as a program that can be used around Queensland. We've been working closely with the Coroner's Court of Queensland and our state coroner to look at improving SUDI investigations so we can address some of those areas that are missing when we're trying to actually work out the preventative factors in these cases. We've also been working with the Queensland Police Force in terms of a first responders guide in helping police and ambulance recognise what is needed to know to help improve the investigation. And finally, newsletters and other publications from the QPQC to look at the particular risk factors in SUDI to get the message across to all clinicians. And thank you. Thanks very much.
so much. I know how much effort's gone into the development of those guidelines, and so it's quite an achievement to get them published and so on. So congratulations on that.